Hello, everyone, and welcome to today's session on using the MLP approach to implement clinic and policy level solutions to address the housing crisis. As the leading voice for leveraging legal services inside health organizations, the National Center for Medical Legal Partnership leads education, research, and technical assistance efforts to create conditions where all health organizations in the United States can leverage legal services as a standard part of the way they respond to social needs. In the move toward value-based care, this is really a time when there's a lot of focus on social determinants of health, and medical legal partnership, is an approach that can help with some of the most complex needs. My name is Danielle Rahajasan, and I will be running technical assistance alongside April Daniels on this learning collaborative. In just a few moments, I will turn over this presentation to our panelists, but before that, I have a few small housekeeping things I would like to run through with everyone. So for today, everyone joined in muted. However, we encourage you to type in your questions in the question or chat pane at any time during the session, as it will really be an opportunity for us to connect and have a rich discussion around our topic today. In terms of handouts, you should have received a welcome packet if you registered for this session. The same document is also available in the handout pane if you want to have it handy today. There will also be a very brief survey that will launch at the end of this session. Your participation and responses really do help us learn more about your needs and how to continue to improve. Just to note as well that today's audio recording and slides will be made available by the end of this week on the webinar page of our website, and we will share that link with you shortly in the chat pane and throughout this session as well. We want to briefly note a quick participation tip. For this particular session, we will be using GoToWebinar, but we will be using Zoom for sessions 2, 3, and 4. And Slack will also be used throughout this entire learning collaborative. So to get the most out of these platforms, we really recommend that you download and install the full-featured desktop software on your computer or mobile device. And lastly, if you have any questions about how we are using these platforms or for specific links, please don't hesitate to email April Daniels at aprilDaniels@gwu.edu. Before I pass it on to Bethany, we want to quickly acknowledge that this project is supported in full by the Health Resources and Services Administration, and that the contents are those of the authors and do not necessarily represent the official views of nor an endorsement by HRSA, HHS, or the US government. Bethany?
Great. Hi, everyone. Good morning or afternoon, depending on where you are, and thanks for joining us. Before we dive into the learning collaborative, the structure, and then the substance for today, I want to run a quick poll, really just see how things are going. So first, let's break the ice. It's been already a long 2021. Hand on your heart, are you wearing your PJs right now? Are we still in 2020? Is it never that you're wearing your PJs? 100% yes. Business on top, PJs on the bottom, or did you literally just take them off a minute ago? Take a moment, answer that first polling question. We just want to know how you're doing. How are things really going? Are you still wearing your PJs on these video calls? All right, let's see. So, oh, a lot. It's interesting. Into the responses, 33% say never. 18% say yes, 100% of the time. Business on top, PJs on the bottom, 30%. Literally took them off just a minute ago, 18% people. I hope those who are in that last category have something else on. Yes, I'm Bethany. Welcome if you haven't met me before. So next quick polling question. Getting a little bit more serious now, right? Why did you decide to attend this event? Are you trying to learn some new things? Are you here to hear from Joel, our co-director, who's well-versed as a professor in these topics? Are you here for the networking opportunities? Because remember, this is a learning collaborative. Or did your boss make you do it? You've got an awesome boss if your boss made you do it. So take a minute and tell us why you decided to attend this event. All right, want to learn new things. Great. And the best thing about having a learning collab, for the 95% who said you want to learn new things, and for the 5% who also said network here for networking opportunities, is exactly why we ran or are running this 4-part series as a learning collaborative instead of just a webinar. All right, and then finally, because there are 3, and I promise they're really, really high level and easy polls. What is your current role? We want to get a sense of who exactly. We know we had almost 100 people sign up for this, and it was a learning collab that's pretty big. So it helps us run these learning collabs a little bit better when we know what your current role is for those of you who have actually joined the live session and who will then view the recording thereafter. Are you civil legal services staff? Are you from an operations or program development sort of role? Are you a medical or healthcare provider? Or are you perhaps in the social services field as social services staff? Apologies for anyone who may be left out. We can only have 4 categories, so we didn't mean to leave anyone out. All right, so we're pretty heavy on the civil legal services staff, as expected and as is historically the case for the National Center. So for those of you in that first category, civil legal services staff, like Joel and I are in the legal bucket, take a moment after this call to really reach out to your medical or healthcare providers. You can see from the poll about 3% are on today's call. And we really want to make sure that in this learning collaborative context that they are engaged in the conversations. But we certainly welcome all, and it's especially nice to see some of those program development and operations staff, and we know some of you cross over. Thank you for engaging. Let's dive in. So I already mentioned this is a 4-part learning collaborative. Everyone should have access to the welcome packet in that, and Daniel already explained that we're gathering right now to figure out ways that the MLP approach can be applied to address the housing crisis, and we're gonna focus on that patients to policy work that is so crucial and critical to getting things done for the patient population. Next slide. In the 4-part series, first you'll hear today from Joel. Of the 4 parts, this is the learning collaborative session that is a little bit heavier on the didactic presentation, but in fact, in parts 2, 3, and 4, where we'll be joined by Ashley, Kate, Jenna, and then Daphne, you will hear them present on scenarios, and then they'll help us moderate a discussion to be able to better evaluate the approach that they presented from your perspectives. And hopefully that'll help all participants really learn from each other, but will give you something to work with, as opposed to just thinking, too wildly and crazily about what the health and housing issues are for the patient populations that are being served. So please sign up for all 4 now. That way we can better manage breakout groups, as well as materials that we'll continue to share in Slack. Also, again, another plug, please go ahead and use in the welcome packet the invite link for Slack. In today's session, after Joel presents, you'll have time to submit questions along the way, and we're going to keep track of those questions and then pose those questions to Joel. April Daniels is going to read those questions that you submit using the questions pane. And then we're going to transition from Q&A for Joel to a moderated chat with you as the audience. It gets a little bit wonky when we're using GoToWebinar to unmute, especially when we have a very big group. So this is our workaround, and we hope it works well until we then shift over to Zoom and breakout rooms. But what we'll ask you to do is use the chat pane to answer, and I'll guide you through this 3 questions about housing policies underway, how health centers are uniquely positioned in your community to address housing insecurities, and then how are the funders and payers really prioritizing these issues at the community level. So we're gonna have the Q&A for Joel, you use a question pane for that, and then a moderated chat with you, and we will select a couple of your responses to those questions that we will pose, and you'll use the chat pane for that. Okay, next slide. I mentioned Slack. I don't know how many times already. We are not slacking off. In fact, Slack is to actually engage more. So welcome packet has an invitation link. I apologize, this is my fault if any of those links are broken or messed up. But right after this call, we're also going to make sure that every registrant for this first session receives an invitation to Slack. Sometimes it goes to your spam or part of your email inboxes. So after this call, later this afternoon, double check to make sure you receive that invitation, or use the invitation link that is in our welcome packet. We will be sharing resources in there. We're going to coax and drive you to Slack so that you can also do that networking and really learn from each other, as opposed to waiting for us to then reach out to someone else in the field or find someone in the field who can help you with some of your questions. So this is that crowdsourcing networking site, and we're using this Learning Collaborative to actually kick this off. So you are, in fact, our brave guinea pigs, and we hope that you will find this resource helpful in the long run. All right. Finally, just a very quick reminder before we move on to Joel's presentation that we do have a 5-part webinar series. This is a learning collaborative that you're engaged in, but we're continuing to run our Health Center MLP Toolkit 5-part webinar series. So if you find that in this learning collab you still need, and whether or not you still need it, we're still encouraging you to attend, but if you still need that foundational information, definitely check out the toolkit. When these slides are shared after today's call, you'll note that this is hyperlinked, and so you're welcome to use that hyperlink to get to the toolkit and webinar series and be able to register for upcoming webinars. If the registration link is not live yet, that's because we're still securing our speakers and getting things set up, but continue to check back in our newsletter. We'll keep you updated. With that short reminder, let's transition to hearing from my colleague, our co-director here at the National Center for Medical Legal Partnership, Professor Joel Teitelbaum. Joel, I'll pass it on to you.
Thanks. Thanks, Bethany, and good afternoon and good morning to everyone. So I'm going to run through a series of slides, and we're going to cover a few different things. The first thing is a bit of level setting. We're going to talk about the MLP approach very broadly. There are some folks in this learning collaborative who are quite new to medical legal partnership, others who are much more evolved in their knowledge of and practice of medical legal partnership. But at the outset, we want to make sure we're covering the waterfront for everyone. So there's going to be a series of slides around what is medical legal partnership and how does it work and the like. And then we'll move into talking a little bit about just a few slides around the role of COVID in our nation's housing crisis, which of course existed long before COVID. COVID has simply exposed and accelerated our housing crisis in multiple ways. So just to give you a sense of where things are in the rental market right now as it relates to COVID, then I'll transition into a few slides to talk about the link between housing and health. Housing, of all of the different social determinants of health, is easily the most heavily studied one. So we have lots of data and information about the role of housing and its connection to physical, mental, and emotional health. And then, as Bethany mentioned, we'll move into Q&A. Next slide, please. So what is medical legal partnership? This is our definition of it that comes from our website, an intervention where legal and healthcare professionals collaborate to help patients resolve social, economic, and environmental factors that contribute to health disparities. What I want to say here is that we need to dispense with the idea that medical legal partnership is somehow an innovation. Medical legal partnership, as we know it today, has been around since the mid-1990s, so we've got 25 years or so of practice and engagement and understanding of the medical legal partnership approach to health. And of course, it didn't start in the mid-1990s. As many of you, I'm sure, are aware, Dr. Jack Geiger, who was a hero, really, of the health justice, health center, and medical legal partnership approach to health, recently passed. It was back in the 1960s with the introduction of the community health centers program that Jack, of course, was instrumental in thinking about the role of law in health centers. And we relied on him as a member of our advisory board for many, many years. And so really the thinking around the connection between law and health, and specifically in community health centers, is longstanding, and it's high time that we stop thinking about this as some sort of an innovation. It really should be much more normative in our healthcare system and across community health centers nationwide. Next slide, please. So this is our famous pizza slice slide. What is MLP all about? It's about embedding lawyers as members of the actual healthcare team. So when you think holistically about what does a 21st century health team look like, one key missing piece in most instances is the use of a lawyer who is well versed in how a particular health center or hospital operates. Hopefully, medical legal partnership leads to healthier patients, a stronger workforce, and improved health equity. And this happens across 4 levels. So if you start at the left, direct legal assistance, of course, bread and butter role of medical legal partnerships. Then you move into training, and that's cross-training, of course, both the health center staff helping to train lawyers and understanding how health centers operate and what health center populations tend to look like, and then institutional or clinic level changes, and then hopefully using each one of those 3 levels to inform the 4th level, which is policy change at the local and community and state and federal levels. Next slide, please. So our research team some years ago, after taking several surveys of the MLP field, settled on 8 essential components of a medical legal partnership. This is taken from an article that was written up in Health Affairs and is easily found on our website. So you can see that we're talking about a lawyer in residence, which is actually having that lawyer on site as part of the healthcare team, some sort of formal agreement or agreements between the health and legal organizations, target population, which I'll come to in just a second. Patients are being screened for their legal and social needs. Designated resources, meaning having medical legal partnership services as part of a line item in a budget, information sharing between legal and medical partners, training on the social determinants of health, and then final additional legal staffing. And so each one of these components has been built out in various resources over the years. You don't just need to turn to the Health Affairs article, but there's lots and lots of resources on our website that will focus in on things like screening and things like how to pay for medical legal partnership and what do those formal agreements look like. You can also find information about these in our toolkits. Next slide. This slide is here to direct you to our mnemonic, which is iHelp, something we use at the National Center to help describe to the field the main buckets of work that medical legal partnership practitioners tend to engage in. The first is income and insurance, followed by housing and utilities, education and employment, legal status, and then at the end, personal and family stability. Off to the right, you can see examples how in each one of those categories, lawyers can help health center staff with all sorts of different issues related to each one of those iHelp items. Next slide, please. So you all will be happy to know that health centers now represent the fastest growing sector for MLP adoption across the healthcare system. This is taken from a resource that we provided in January of 2018 about where medical legal partnerships are in health centers, how they work in health centers, and how they are funded in health centers. So again, we'll point your attention to our resources page at the National Center's site, and we'll come back to some additional resources at the end. Next slide, please. So what does a typical health center with an MLP look like? Well, not surprisingly, they probably look like what you would guess if you were forced to guess. First is that those with MLPs tend to have more staff, higher patient volumes, and a greater number of sites than those without MLPs. They typically have larger budgets. Again, not a surprise. MLPs tend to be found in health centers in large urban areas, which is true of medical legal partnership generally, not just in health centers, but the number of MLPs in rural situated health centers is growing and something that we've been focused on more for the last 2 or 3 years and hope to focus on this going forward as well. And then finally, health centers with MLPs typically utilize health IT to coordinate or provide enabling services. So if this sounds like your medical legal partnership, it at least tells you that there's lots of precedent in the health center field for setting up and operating medical legal partnerships. If your health center doesn't look exactly like this, it doesn't mean that you're not well suited for a medical legal partnership. It just might mean that you would start at a slightly different place on the spectrum than would a health center that looks like this one. Next slide, please. So let's move into housing a little bit and away from what is medical legal partnership. This slide is taken from the 2019 annual report of the Legal Services Corporation, given the folks on the call today, given one of those early questions. We know that you're well versed in the Legal Services Corporation. the primary method by which we finance and deliver legal services in this country to individuals who are low income and have other issues accessing legal services. So the top 3 service areas, and this is not specific to MLP, but across the LSC funded legal services sector, are housing, family law, housing, and income maintenance. So not surprisingly, given that there's a nice cross-section of medical legal partnership across LSC funded programs, you won't be surprised to learn that housing work, both unlawful eviction, landlord-tenant, and as you will see, additional issues, is a primary focal point for medical legal partnerships. Next slide, please. So how lawyers help in solving social determinant of health problems for individuals specifically experiencing homelessness. So let's get a little more granular than that last slide. So you can see down the left side, the social determinant of health, those that might include economic instability, neighborhood and built environment issues, equal access to work and education, health and healthcare, and safe homes and social supports. And again, some examples of how lawyers can help across each one of those things, like denials of public benefits and health insurance and cash benefits, certainly in the built environment and housing world, substandard conditions and habitability, employment and education discrimination, emergency access to insurance benefits, and things like custody and guardianship for kids, garnishment of wages for child support, and the like. Next slide, please. And then finally, just a bit more granular, if you look off to the right, some of the impact on health and healthcare. I'll dive into more on this just in a few slides, but things like stable, decent, affordable home helps individuals and families avoid costly emergency room visits as a result of their homelessness, and consistent housing, heat, and electricity help people follow their medical treatment plan, something that we've seen time and time again in the MLP literature. Next slide, please. So let's look a little bit at what COVID has wreaked with regard to renters in this country. This is very recent data. This is taken from December 2020. It is from the Center on Budget and Policy Priorities, as are the next 2 slides. So that what you can see here is that nearly 20% of renters as of December are not caught up on rent during the pandemic. Not surprisingly, again, with so many of our health disparities, they hit much harder in communities of color. That is represented here. So you can see across the top, all adults at about 19%. Those numbers climb for other multiracial, not Latino groups, for Black, not Latino groups, for Latino of any race, and then for Asian as well. Whites well below the national average of all adults. Next slide. That 20% number jumps to about 25% for those who are not caught up with rent but living with children. So you can see a pretty vast disparity there between households who have children and are not caught up on rent and those that don't. So obviously finding it harder to make ends meet in families, and renter families specifically, who have children. And then finally, the next slide. So that number jumps to somewhere between 40 and 50%, where children are in renter households and whether they're facing food and or housing hardships. So a very strong link between food insecurity and housing insecurity. Kids who didn't get enough to eat were represented by 32% of responding households in December. Not caught up on rent, again, you see that number hovering right around about a quarter. For both, 14%, and either is all the way up to 46%. So whatever COVID is doing in the housing space, it is clearly wreaking havoc both on the housing front, but also causing folks and families to choose between whether to feed their families or to house their families. A pretty unconscionable circumstance in this country. And these 3 slides that I just presented, truly just the tip of the iceberg. There has been so much work, so much written, so much talked about around housing, and doing everything we can to make sure that the eviction moratoria are in place. I would note that a lot of the focus around eviction moratoria and homelessness related to COVID has been spent talking about the renters. It is worth noting indeed that many of the landlords in this country are small business owners, and they are hurting too. And some of the work that I've been doing on an ABA task force around COVID and legal needs is focused on the fact that we also need to address the hardship being suffered by those small business renters. As they don't get paid their rent, they too are struggling mightily. And so a lot of the work that the ABA and other organizations have been doing individually and collectively have been asking the incoming administration to put some additional focus on the renter hardship, on the landlord hardship as well. Next slide, please. So what do we know about the effect of housing insecurity and housing deficiencies on health? Well, the research was pulled together nicely in an article by Lauren Taylor in the Health Affairs blog a couple of years ago. The research sort of falls into 4 different buckets or pathways. The first is the stability pathway. So there's plenty of research that details what the health impacts are of not having a stable home. The second pathway is safety and quality, lots of health impacts around conditions inside the home. The affordability pathway, there's less research here, but still enough to draw some conclusions around the health impacts of the financial burdens of high cost housing and how many folks in fact are paying more than 30% of their total income on rent or mortgage payments, 30% being the sort of generally accepted international and national standard. There are many folks in this country who are paying 50% of their total income on rent or mortgage, and then a very substantial subset of that who are paying up to 70 or 80%, which then gets to making it very difficult for them to make difficult choices about whether to feed, whether to house, whether to clothe, whether to educate, and so on, their kids and families. And then the fourth and, go back one last for a moment there, thank you. The last bullet there, the fourth and final pathway is the neighborhood pathway, detailing the health impacts of neighborhoods, including the environmental and social characteristics of where folks live. Next slide, please. So what are some examples of the consequences? So these bullets are not restricted in order to the 4 bullets that I just presented, but rather these are 4 different buckets of consequences related to one or more of these 4 pathways. So the first one is very specific to health. Across those 4 pathways, you see increased mortality, trauma, depression and anxiety, physical health morbidity, increased hospitalizations, increased food insecurity, higher risks of teen pregnancy, higher drug and alcohol use, increased suicide, and certainly increased health expenditures. So specific to one's health, physical, mental, emotional, we absolutely have plenty of research now to show that those 4 housing pathways are causing major problems for folks in their health and health care. The second bullet there, there is a body of research that is specific to showing disruptions to the employment status, to social networks, to education, and to the receipt of social service benefits. Turns out that folks who are having housing insecurity issues are less likely to have a usual source of medical care, and that leads to bullet 4 oftentimes, which is they are more likely to postpone needed treatment and go without prescribed medication. So as I mentioned at the outset, of all the social determinants of health, regardless of how you think about those, housing is certainly by far the one that is most studied and most closely connected to health and healthcare. My guess is that as we move into more closely studying other social determinants of health, like transportation, like the link to education and others, we will certainly find that the link between those social determinants and to health and healthcare are very close, if not equal to what we're finding in the housing space. Next slide. So we wanted to connect you to some existing resources. This one, Homelessness, Health, and Medical Legal Partnership, we did in conjunction with our colleagues at the National Healthcare for the Homeless Council. And so we wanted to alert you to the fact that there is already resources at our website around homelessness and health and housing issues. Next slide, please. Because this is a Patients to Policy Learning Collaborative, we wanted to highlight our Patients to Policy series. We have a handful and more coming in this series on our website. This one was specific to the Medical Legal Partnership at the Erie Health Center, which built a multi-state coalition that helped move HUD to update its public housing-led regulations, and now they're working to pass federal legislation that would require lead inspections of all federally assisted housing units. So this is not the only Patients to Policy story that we have, but if you want to get a sense of the kinds of information that these Patients to Policy learning collaborators can lead to, you might want to take a look at those stories on the website. Next slide. And then finally, I believe this is a resource we put out in this past June, 3 ways to help patients with evictions and foreclosures during the COVID-19 pandemic. We held multiple national webinars to understand what was going on in the MLP field specific to COVID a few months after the outbreak started here in this country. And we've put these to paper in this particular resource, and there are others, and certainly more coming as we move through 2021. I think, Danielle, if you move to the next slide, yes, I think we're going to move into the Q&A portion. Oh, I did very well. So we're right at the bottom of the hour. We were hoping to leave about a half hour of time for Q&A and for moderated discussion, and it looks like I have hit my benchmark.
You're good on meeting the benchmarks, Joel. Thank you. So let's get April unmuted to see if we have questions coming in from the audience first, or participants is what I should really call everyone who's joined us today. Take a moment. If you have any trouble, by the way, using the questions pane, or for some reason it's not showing up or not working because you're running from the web, use a chat box and just send us your question so that we can ask Joel a couple of questions. April, as I give you a moment to check our Q&A, Joel, the question I would first pose to you is that as we think about the policies that MLPs can engage in to really address the housing crisis, folks are looking at federal, state, and then perhaps like a smorgasbord of very localized policy issues. Is there any policy that you would like highlight at any of those levels that folks should, or is there a way that you would suggest folks should really tackle tracking the policies at the different levels, or would you recommend that they focus on a specific type of policy at a certain level?
I don't think it's a one-size-fits-all answer. Certainly with respect to COVID, at least, because many of the state laws right out of the gate were so very different, and even at the city and community level, they were very different. It made it hard to think about a one-size-fits-all. Outside of a COVID context, there's no question that there is plenty out there already, and I don't think we should spend time reinventing the wheel at this point. There's plenty out there that does a lot of really wonderful tracking around the federal policies, both COVID and non, certainly state policies, and at the local level, they can certainly be a little harder to find. Those get tracked less frequently, but even there, I think we're making some progress. So I don't think there's any one particular policy, especially outside of COVID. When you're talking about COVID, it just simply has to be creating the best backstops we can to prevent crisis. COVID is potentially, if we don't handle the response well, COVID is potentially going to create the greatest eviction tsunami and therefore housing crisis in this nation's history. The numbers would be truly staggering if we simply pulled back all of the moratoria that were in place. You're looking at potentially, 40 million people at risk of eviction, which is unheard of. We have probably somewhere between 1 and 2 million evictions in this country nationally, which is 1 to 2 million more than we should have, frankly, by my count. But so as long as in a COVID context we are creating crisis backstops, then of course you can move into all of the problems that we had pre-COVID, and there are many, they are legion in our country with respect to housing. And so there's plenty of work to be done. There are plenty of policies to be focused on. It really, I think, to your point, does involve sort of biting off a piece of that and trying to focus initially on where you can make the most change, the most benefit most quickly.
Mm-hmm. And then we know from folks in the field of academia like you, Joel, or like the Emily Benfers out there that people might be tracking, when we focus just on evictions, right, that removal, folks need to go a step further and look at what that means, in addition to losing one's shelter, and then the anxiety, all of the health effects leading up to that, that scary moment of an eviction. Even if you are able to recover your housing, you're left with something like a money judgment, right, or those arrears. So have you any suggestions for those who are working in that space, as like I have come from in the civil legal services world? One bit of advice we used to give clients was, you know what, just save your money. Don't try to pay the back rent. Don't save your money. But at the policy perspective, because that's the direct services level, at the policy level, is there something that you would recommend or highlight that an MLP can try to push for? Or is there something that you could recommend between the healthcare providers who are doing the screenings to really inform the legal services providers of the problem that can be addressed at the policy level?
Yeah, so one of my favorite trends at the moment happens to be a legal intervention. So we, based on some work that was done in New York City some years ago in making sure that the city was providing legal assistance to individuals who were threatened with eviction. It turns out, of course, not only that if you give folks legal assistance in their eviction proceedings, they're able to stay in their house or their apartment like 40 or 50% more frequently than if not. There's a massive divide in this country between individuals going into as potential evictees into their housing court lawsuit. Only about 10% of those individuals tend to have lawyers on hand, whereas the landlords, about 90% of the time, tend to have legal assistance on hand. And as a result, you get those 1 to 2 million evictions every year. It becomes very easy to evict someone when you've got legal counsel at your side and the renter does not. And so based on the research that came out of New York, which showed not only that, of course, you can keep people in their homes with legal assistance, you can actually save money because it becomes much more expensive to house individuals in shelters or in other locations when you evict them. And so there are several other cities that are following suit. Last time I saw a list, I think we were up around a dozen or more major cities who had already implemented some work similar to what was going on in New York, or were piloting programs. And so I would invite individuals to become familiar with those programs. They're pretty easy to find and understand, and then tailor them to their local needs and resources. But I think that's one of the most profound interventions that we have going for us, which is we know that if we simply focus on giving folks access to legal services in these eviction proceedings, we can keep them sheltered in a way that we can't without it.
Mm-hmm. We should call it the Civil Gideon movement. I can't wait to see what happens. I recently saw it in Baltimore as well, and I think the state of Maryland may take it up. So really great work that we're seeing there. I'm going to pivot to some questions that came in, Joel, from the audience. April, should we unmute you so you can read those questions out?
Yes. I got the question asking about your reference to how MLP is not a novel concept. Can you provide any other novel concepts in creation that look to solve the complex issues in health, human health, that you are aware of?
Certainly not in the legal space. It's pretty well understood now, and I'm hearing more and more from folks who are not engaged yet in the work of medical legal partnership, but want to learn more and want to become engaged, that their understanding is that this is the primary intervention. There are certainly many, many interventions that I'm less familiar with that are non-legal in nature, around financing mechanisms and around collaborations and the like, and there's plenty of literature around those. But in the legal space, it looks like the use of medical legal partnership in all of its various forms is really taking hold as the primary method by which we conjoin the two fields, the health fields and the legal fields, which is exciting, and it's also not a burden, but it's a calling, because when I say we're not an innovation anymore, we're talking about having more than 450 medical legal partnerships right now in existence, and perhaps more if we don't have a perfect handle on how many are out there. And so that I don't think is an innovation anymore, but it is a drop in the bucket, and there's a difference between those two things. So while I don't think we need to be looked at as something that still needs some sort of trial and error aspect to it, we do have to consider the fact that there are thousands and thousands of health centers, thousands and thousands of hospitals out there that don't have medical legal partnership. And so it really is about figuring out how to scale a very flexible, very modifiable, somewhat amorphous intervention like medical legal partnership to fit the needs and resources of specific health centers and of health systems. So I don't have, and maybe Bethany or others do, I don't have a lot of other legal interventions, but there's certainly a literature out there around other kinds of health interventions around social determinants of health. And that's a really broad literature right now. And there's lots of folks and organizations and agencies at both the state and federal levels moving in more and more to that space. I think we were on a call this morning, and Bethany, you referenced the state health official's letter, where CMS was talking about ways in which Medicare and Medicaid programs can be moving into the SDOH space even more. So there's plenty out there. It's just a matter of trying to figure out what might work best for your particular need. And Bethany, you may have additional thoughts.
No, that's it. I totally agree. And recently presented on a webinar where I asked the organizers to please not call us new, or maybe change it to innovative, because it is, the concept itself isn't new. Joel mentioned Dr. Geiger really engaging a lawyer, and also in his social medicine work, prescribing food to children. And so the concept that you all are carrying out through these medical legal partnerships isn't new. Collaboration beyond the four walls of a healthcare provider or just a legal services provider is not new. This approach, however, does have, as Joel walked through in his slides, some specific components. And so I think, just so you all know, as this is a learning collaborative, we too here at the National Center are learning. And so our next set of work with you all in the field is really to move the field forward into what that next innovation carried out by a model really looks like. In addition to scaling it, what does it look like content-wise, substantively? What is it that you all can get done in the next iteration of medical legal partnership? So it's perhaps not an innovation anymore, but its various iterations continue to evolve. That's all I would add to that.
Yeah, that's a good point, and I'll just add to that. I think it is fair to say that the next 5 to 10 years of MLP practice is really MLP 3.0. So I think we are beyond the innovation stage. I think there's enough out there to lay claim to an intervention that works differently across different spaces and across different populations and across different conditions. But there's some there.
We have some more questions for you, Joel, before we move into the chat. This is pretty much the chat with the audience, but I want to make sure April gets the 2 other questions that are directed to you. Sure. April, go right ahead.
Thank you so much. Joel, can you provide recommendations on maintaining contact with unhoused MLP clients or developing systems with shelters to stay in contact with clients who've become unhoused?
Ooh, that's a little outside my area of expertise. I'm thinking about folks like Bethany. I'm thinking about folks like certainly Mallory Curran and Emily Benfer and others whose work is much more specific to housing and the processes of staying in touch with clients. I myself don't have any, but there have to be in some of our housing coalition partners. as part of this NTAP, I'm sure have information on that. I'm wondering if we can't get something out to members of the Learning Collaborative in around that issue. It's a great question in a space where I think a lot more information sharing would be valuable.
Yeah, and so I'm glad the previous question came up about innovations, as well as a call we had this morning to remind us that there have been some folks working on medical respite. So since this is a policy-focused housing or shelter learning collaborative, right? Think about what some folks have been doing. It's few, but I think National Healthcare for the Homeless Council also partnering with us as a training and technical assistance provider through our HRSA grant has been highlighting and moved with, I think it's more than just in New York, on a concept called medical respite. And so that's moving from that patient issue where you're working with patients or clients who are hard to keep track of, and then looking at a policy approach. And I do believe, as we heard this morning, got some examples coming out as it pertains to implementation. But yes, since this is a learning collaborative, we can definitely reach out for resources and maybe even invite some of those folks like Emily Evanfer, Mallory Curran, and others working in the space at the medical legal partnership level to come into the Slack channel and help to drive that discussion and share resources. That's another plug for Slack. It is a learning collaborative, and the Slack page is so that we can crowdsource to be able to answer and share information on precisely this type of question. But that's my one example that I would point out, since I was reminded of the medical respite example just this morning.
Yeah, it's a great issue for one of the other 3 learning collaborative sessions. I can't recall off the top of my head which one it might slot best into, but yeah, a really good issue, right, for discussion.
Yep. So probably session number 2 with Ashley. She's from Camden Coalition, and they work with patients who are complex, and many of whom are also homeless or housing insecure or unstable. So we'll crowdsource for that. Just seconding what Joel mentioned. April, I know you've got another one for us.
Yes, I do. MLP seems to be urban solutions, meaning rural America, hospitals are closing, etc. Can you share your thoughts on urban, rural, non-connect? And if you
What was that last part of the question, April? Sorry, the non-connect?
Yeah, if you can address if you feel that there is a urban or rural non-connect, or if you feel that there is one.
So can you tell us the question specific to the MLP space? Is that the question about, because MLP seems to be something of a more urban intervention?
Yeah.
I'm going to guess. Got it. Yes, it's certainly the case that if you look at the map that shows where medical legal partnerships are located, like so many things when it comes to social services of all sorts, you tend to find more of the outposts, the locations, the resources in urban and immediately suburban areas. Just as, however, medical legal partnership used to be viewed as not just a hospital intervention, but a pediatric hospital intervention, because that's where the first medical legal partnership, as we think about them today, was created up in Boston. It's no longer the case that MLP is simply a pediatric, much less a hospital intervention. Perfect evidence of that is this learning collaborative that is sponsored by HRSA. And so my point is that there is plenty of room for us to be able to move into more rural spaces and communities with medical legal partnership, particularly around technological issues and the ability to provide legal services through technology. Even before, however, COVID, there was work in the MLP space, both around telelegal services and simple face-to-face interactions for medical legal partnerships in more rural communities. And COVID, I think, is only going to accelerate in the legal field the ability to provide legal services through technology And so I think we know enough now about how medical legal partnership works, and because it is so malleable, and because of what COVID has shown us can be done through technological platforms, that we have a really good inflection point to be thinking about how to move medical legal partnership more thoroughly into rural areas. So again, it wouldn't even, in my view, be something like an innovation, because the MLP approach, we know, works across sites, it works across conditions, it works across populations. We know it can work in rural settings. We have really wonderful evidence of that, of Alaska, among other places. And so I think it's just a matter of sort of putting our heads down and making an affirmative effort to move into that space. I don't think there's anything about rural communities that will make it harder for us to have medical legal partnership services there at a level that is much more frequent and more in line with what we see in urban communities. It's just not been the case historically.
Joel, the clarification that came in was basically what happens, because especially, and I remember I had seen this when I was working in the health center world, but what happens when that rural provider, like the rural hospital or the medical provider in the community, is closing? So what is an MLP to do when your medical, the M in the MLP, is disappearing? I would just quickly offer that this is a policy issue when you see rural hospitals closing. And so that is a conversation that you probably should have with the rural hospital folks and say, well, what is the policy that's leading to this? Is it funding? Is it something about your reimbursement mechanisms? Have those conversations, even though you are focused very heavily on their patient/client population and the direct services. There's a role you can play where you're making a value statement that can help them stay in a community, because a lot of times the rural hospitals are literally the only one in that community providing the medical services. And so that's where you might be able to interject and help to propel whatever they're trying to do to survive.
Got it. Yes, a different and very important question, one that's well taken. My recommendation is to always, when you are a medical legal partnership practitioner, meaning that when you are working at a health center that has an MLP and you utilize those services on behalf of your patients, you also, I think, have something of a responsibility to understand the other kinds of legal services providers in your community, which is to say, don't simply rely solely on the medical legal partnership. If there are law schools somewhere in the vicinity, you should have a connection to that law school and to that law school's clinical program. If there are law firm outposts in your community, you should have some sort of connection to those law firms and their pro bono programs. And there are other kinds of examples like that, and certainly the LSC provider in your community. And so if that community health center, that public hospital closes, you're not completely left out in the cold, that you do have existing relationships, and there may be some way to plug some gaps, at least in the short term, with your patient's legal needs with those other kinds of providers, even if they weren't necessarily involved in the medical legal partnership. It's basically having those emergency services, those safety net services on hand in the event that you should need them.
All right. So what I'm going to do is, looking at the time, we're going to move to the next slide. And thank you so much, Joel. Thank you for everyone for sending questions. What I'm going to do, because of the time, and we did plan for this because we wanted to make sure that we really optimize the time that we have with Joel today, was at least pose one question back to the audience, and then we're going to take the other questions and then we're going to put them in Slack. That way we're purposely driving you to engage in this learning collaborative. So take a moment, and in the chat box, and we'll highlight just a couple of them, take a moment right now, the question that's on the screen, to tell us, what is the housing policy initiative that your MLP is actively working on in your locality? And when we say actively working on, you could be considering a policy, you could be exploring whatever the policy initiative is. So in other words, it could be at any stage. Perhaps you've already explored a policy and now you're into the implementation, but take a moment and type just in a couple of words so we can highlight it for everyone's benefit here. What housing policy initiative is your MLP working on in your locality? Let's get a sense of what folks are working on. We highlighted a couple of examples. Some folks asked about rural hospitals or rural areas in the medical provider closing. And so perhaps that's some of what we may cull from the group today before we shift to closing out. Then we're going to ask April, do we have any examples I can highlight? See if we're getting anything in. And April,
I haven't received.
Go ahead, April.
No, I was just sharing. I haven't received one yet.
Okay, all right. So this is my call to action. This is the year of action for all of us.
I apologize for. I see eviction defense and right to counsel legislation. A lot on mediations in evictions. Jennifer here shared that they are trying to address hospital discharge to homelessness and establishing or maintaining contact with unhoused clients. Working to draw attention to lack of access to outpatient behavioral health care for the unhoused population in their community.
Right.
Yeah, so infestations as well.
Some people that's pre and post COVID.
Sorry?
That's certainly pre and post COVID, right? Several of these are they've existed prior to COVID as issues, housing issues that patients and clients have been facing. Sorry, go ahead, Danielle, if you want to highlight a few more.
Yeah, some are doing training on the impact of the pandemic on housing issues. The goal with that is to train, to help medical providers to recognize issues. And as a legal provider, they're trying to expand staff and volunteer expertise on housing issues to meet these increased needs.
Great. Thank you, Danielle. So we have a sense of, at least using just this one question, what folks are beginning to work on. We're going to use the other questions to really drive a conversation in Slack. So let me just ask Danielle, thank you again for reading those out, and April for moderating our Q&A for Joel, and for Joel for presenting. If we could move to the what's next slide, because I'm already alluding to what's coming up next. Want to remind folks that we have 3 more sessions. This one today was the heavier of the presentation sessions. We're going to use Zoom for parts 2, 3, and 4, where we talk about patients with complex needs, a focus on children, and then generally evictions and city ordinances, looking at the utilities space. Those will, depending on the size of the group, allow for us to do some breakouts and then unmute you, let your video show so that you can actually talk to us. So please sign up for those now so that we can prepare to either have folks in one room or in several breakout rooms, and so that our presenters can know how to tailor their presentations, as well as the moderation aspects of and facilitation aspects of those discussions. So sign up now. And then, as I mentioned several times, we're in Slack. I already got a couple of pop-ups on my screen letting me know that some of you have already been taking advantage of the invitation link that has been sent. Right after this call, we're going to make sure every registrant for part 1 receives the Slack invite, and we'll continue to do that as people register for the other parts 2, 3, and 4 for this Learning Collaborative. And that Slack page will not shut down after this Learning Collaborative. That's going to be what we use to really launch an MLP 101 site, and you are welcome to further invite your other MLP practitioners. If it gets too busy, we'll figure out how to manage financing that Slack workspace. But our goal is really to make sure you have some place to continue to learn, share, and not get lost in our inboxes when you reach out for help on who out there is doing what in the MLP field. So with that, next slide. Let me thank Joel Teitelbaum again for presenting on today's Learning Collab presentation. And then our colleague April Daniels, as well as Danielle Rahajasan for helping us to really facilitate, moderate the conversation for today. We'll all be in Slack and looking out for your questions, as well as making sure you're able to receive resources in a timely manner. Let us know if you do need any help accessing Slack. We're still on Twitter, and we will continue to post things on our website, like the registration links for the next Learning Collab sessions and webinars. Thank you all for joining us today. We look forward to actually hearing from you and seeing you on the next sessions. Please, 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 this is HRSA funded. They like to know how well we did, and we definitely want to know how we can further improve. So when you click out and close out today's GoToWebinar, don't forget to fill out our evaluation form. Thanks for joining. Stay safe out there, everyone. We will see you at the following sessions. Bye-bye.